Hi, this is Dr. Donald Pelto. I want to go over at this time a patient's guide to bunion surgery. This is for you if you want to learn everything and then some about bunions, what to expect, and what you're going to have in your experience. Specifically, I want to go over the 10 most common questions that my patients have regarding bunions. First of all, what causes a bunion? What are the treatment options? When should you consider surgery? How do you choose a surgeon? What is needed before surgery, during surgery? What's the ideal procedure that you're going to need? And what's it like after surgery? And what are all the possible problems with surgery? That's one where I really go into detail about the possible complications. You really want to pay attention at that point. And then, will the bunion come back? That's the most famous question that everyone wants to know about. So let's get right in there. What causes a bunion? First of all, a bunion is caused by a bump on the inside of the big toe. And it's commonly passed down through your parents, grandparents, someone in the family. If they have that foot type, you're going to be more prone to developing a bunion deformity. It can also be caused by a mechanical instability. If your foot is unstable, for example, if you have a flat foot or a foot that kind of goes to the side, the tendons can pull harder on one side than the other and cause the bone and the toe to move in and the tendons to move things around. As well, if you have poor shoe choices, that can cause a bunion. Because the poor shoes, as you can see, they're tapered in the front and they squish the toes together, and this makes it harder for the toe to be in straight alignment like they should. What are the treatment options you're going to have? Well, first of all, there are some non-surgical treatments and then there are surgical treatments. Let's go on and talk about some of the non-surgical treatments first of all. Initially, I tell all my patients to try wider shoes. You can see here's a type of a shoe right here. This is a gel Cayano. It has a wider front of the shoe. I still don't like the tapered type of a shoe. There's certain shoes that are called minimalist shoes that offer a little bit wider of a front portion of the shoe so your toes aren't cramped in there. There are certain types of pads that can help as well with some of the pain. Once again, a pad on the side. This can help if there's any bump pain. There's a pad that can go between the toes that can separate them a little bit. These are called smart toes. These actually go between all the toes and they space out your foot. And there's also a pad that can pull things down. These pads, once again, they're temporary. They're helpful to help you with some of the symptoms that you're having, but they're not going to resolve the problem, because the problem normally is a bony problem and a joint problem. Also, a toe alignment device. These aren't going to help. These are like the smart toes. And there are different types of nighttime braces that people ask me that they'd like to try. All these are good to try, but I don't really guarantee any success in changing the problem with the bunion. They can help you with the symptoms. But once the symptoms get too bad and you have pain in the joint, I usually start with a steroid injection. This is an example of a steroid injection we use with a needle. About 2 to 3 cc's of material. It's a cortisone. We use a short and a long-acting steroid and a short and a long-acting Novocaine to go in there. We can't fit all 3 cc's in there, but we fit a portion. Sometimes you go right in the joint, and then sometimes you go right on the side of the joint where there can be a painful sac of fluid in the area as well. That's how a steroid injection is done. You only want to do about 2 to 3 of those a year. Doing too many of them can be harmful to the joint. When should surgery be considered? This is everyone's big question. And you really have to think well about doing surgery on your bunion. Not all surgical treatments, non-surgical treatments fail. That's the first thing you want to do. If you're failed at trying all the other stuff that we talked about, then you may want to consider surgery. Also, it's not for cosmetic purposes. You want to do a surgery if you're having pain. If that bump on the side is painful, if the joint is painful, if it's painful in your shoes, if you can't fit in shoes, maybe you're able to wear certain types of shoes, but you can't wear the shoes that you like. So that's another reason. And then when you've stopped growing, we don't do this as a rule to children that are very small. Some young girls or young boys can develop bunions when they're very young, but we want to wait until they've reached skeletal maturity. Maybe until the age of 16 or 17, until the bones show that they've stopped growing. So those are some of the things that you should determine of when a good time is to have surgery. A lot of the patients, they come to us though they've already tried some of the non-surgical aspects and they're really ready for surgery. They want to know, well, is it necessary? Surgery for a bunion is something we call elective. You don't have to do it. You're not obliged to do it. But if you think it will help you, we can go through it, but we want you to make sure you understand the risk complications that can go with it. Also, a few important questions I always ask patients. For example, do you smoke? If you smoke, it can cause a slowing down of the healing, both of the bone and of the skin, and you're at greater risk of developing an infection. Do you have diabetes? How is your blood sugar controlled? If your A1C is elevated above 7, you want to hold off on surgery until you get your blood sugar under control, because higher blood sugar can give you greater risk of problems during surgery, greater risk of infections, and greater risk of complications. Also, do you have a history of heart problems? You wouldn't want a heart problem to cause a greater problem than the surgery itself to fix the bunion. If you have other health conditions, you need to get them under control before you consider this elective procedure. Do you have a history of fibromyalgia or chronic pain? If that's a problem, be aware, because when we're fixing the bunion, you may have other problems. It may be very painful, or the pain may be out of proportion if you have a history of chronic pain. And then, have you ever had a problem with surgery in the past? If you've had a problem, you need to let us know, because there is a risk of having surgery and different problems with surgery again. Let's go on to how do you choose a surgeon. That's something a lot of patients, they have a problem with their bunion, and maybe they're searching online, maybe they're talking to their friends. Really, how do you choose a surgeon? Well, first, I would recommend getting a referral from your doctor. Go to your primary care doctor and ask who they recommend, who they've had good success with in the past. You can also refer to a friend that has had surgery before, and then also ask the surgeon to see other surgeries that they've done before, and also see if they're board certified. Look at these surgeries to look at the before and after. No one can give you a guarantee, but you would like to find a foot and ankle surgeon that does a lot of bunions. You don't want to find someone that just does bunions some of the time. Also, let's go on. Now, let's say you've decided to go on to have surgery. It's been painful, and you want to know what you have to do before surgery. The time between when you book a surgery and when it's done, it may be a couple of weeks or it may be a couple of months. A lot of patients, they actually decide, well, I want to do it around New Year's, so they book it 3 months in advance. Other people say, well, I want to do it in the summertime, so they book it a number of months in advance for that. When you have the date, you have to start preparing. And the first thing that's going to need to be done is a preoperative visit with your doctor or at the hospital. This preoperative visit just goes over your general health to see what medications you're on, to see if you're healthy, if you're able to tolerate both the surgery and as well the anesthesia. Also, before the surgery, you have to find a ride on the day of surgery and plan for time off work. Don't think just because you have a bunion surgery you can go back to work in 2 or 3 days. It's recommended to take a couple of weeks off, if not longer. Especially if you have a standing job. If you have a standing job where you have to wear shoes, you can't go back to work if a bone cut is done for a number of weeks. If you have more of a sitting job, you can be able to go back to work a little bit sooner if you're able to elevate your foot and put ice on it. Be aware as well that the day before surgery you shouldn't eat anything or drink anything after midnight. The reason we do this is because of the anesthesia, because you wouldn't want to have any problem vomiting up any of those things that are in your stomach prior to surgery. Also, the hospital, they'll call you the afternoon before surgery in our case, and you'll be getting a cam boot and a shower cover and crutches before. So here's an example of the cam boot or a walking boot, here are the crutches, and here's a shower cover. These are all essential parts to the surgical day. What's it like the surgical day? Well, you're going to arrive about an hour before surgery, maybe an hour and a half. Someone will be taking you there. Children are usually, and diabetics are usually the first surgery, so if your surgeon has a number of surgeries, you may be first, you may be later on. You're going to change your clothes to something more comfortable, and you'll be getting an IV, and they're going to put in antibiotics for the surgery. This is usually done in all surgeries, but it's up to your surgeon preference. The typical antibiotic is 2 grams of Kefsol, but if you have a penicillin allergy, we use 600 milligrams of clindamycin. And if there's another allergy to that or a history of a MRSA infection, we may use 1 gram of vancomycin. Those are the different types of medications. We give them prior to surgery and usually not afterwards, just at the time of, in case we're putting an implant or in case we're doing a more involved and long surgery to avoid the risks of infection. Your surgeon will arrive and fill out the paperwork. Most patients get monitored anesthesia care. What that means is MAC. That means that you're going to be put into twilight with a medication called propofol. You're going to be kind of in la-la land, and your doctor is going to numb up your foot, and then you will be you'll wake up, but you're not going to be totally awake. And this way, it's the safest type of anesthesia, and you'll be able to recover well after, quickly. If you have general anesthetic, it's going to take you a longer time for you to recover. If you are anxious, they're going to give you some medication, and also you have to be aware that most surgeries take an hour to 2 hours, depending on how many other procedures are needed. What surgical procedure do you need? There's a lot of different procedures that can be done. It depends on the severity of the condition, and it may be done at the end, at the middle, or at the base of this bone. This bone is called the first metatarsal. And if you can imagine, if you're trying to correct this bone and move this bump over, the further back you go, the more leverage you're going to get. If you shift something back here, it's going to swing everything over a lot easier. But as well, this is more of an unstable area, and you have to stay off your foot for a longer period of time. So here's an example of a head osteotomy where the bone is cut through and a screw is placed into the head. That's called an Austin bunionectomy. This is called a scarf bunionectomy, where you actually do a Z-cut in the bone and shift it over. And here's one that's done a lapidus, which is done at the base to shift the bone over and correct the bunion deformity. This tends to be done more with a foot that's more unstable, and it's a very effective procedure. All these are effective, but that's how you determine what type of bunionectomy you're going to need. If you have a hammer toe, you may need surgery for that as well, if the hammer toe is painful. So a hammer toe is a curvature in your toe, and to correct it, you have to correct the bone or remove the bone where it's elevated. So for example, you remove it here on this hammer toe, here on the claw toe, and here on the mallet toe. Sometimes you just remove the piece, and other times you actually put a pin down and you fuse the area. That's called a toe fusion. That's typically done in conjunction with the bunion. You don't want to just fix the bunion, you need to fix the hammer toe as well. Some patients that have pain in the bottom of the foot, they may need something called a Weil osteotomy. This is a shortening osteotomy. As you can see, the normal length is out here. When you shorten it and you put a screw in, you're able to remove it and shorten this area. This reduces any pressure to the front of the foot you may have under one of the hammer toes or on some of the other toes. It treats a condition called metatarsalgia. So metatarsalgia is pain to the bottom of the foot in this area. So let's go over exactly what's involved in the procedure. If we're doing a bunion, first you need to make a skin marking, and you have to do the incision. The skin incision is usually just on the inside of this long tendon. This is called the extensor hallucis longus. You make it right to the side. Usually what happens is you hold open the toe to the right position and then you make the line. So it doesn't usually look curved like this. This is just for figurative detail. You like to go right to the side of this extensor tendon. Next, you take the dissection down to the area of the extensor tendon and you cut through the capsule. The capsule is the area that houses all of the joint fluid, and we usually do an inverted L capsulotomy. So you have to cut through here, cut the tendon that's causing some of the deforming forces, and then do an L cut on the side and then back down. That's an inverted L capsulotomy. Once you free up all the bone from the side of the bone, you then cut through the extra bone, this bone right here, and then you cut through the bone here and shift it over if you're doing like an Austin bunionectomy, which is right in this area, and then you put a screw in to hold it in place. Some people use pins, some people use staples. It really depends on your surgeon's preference. After the surgery is done fixing the bone and you flush everything out, then you close the skin. So here's an example before and after. You can see there's a little bit of a line right here where the incision was. And here's more of a fresh one. You tend to get a lot of bruising after the surgery, and these little things are little pieces, strands of the stitch that's done in here, and these are the stereo stitches that go over the top of it. So that's the procedure in detail. If you have to fix a hammer toe, that can be done at the same time, or that Weil osteotomy can be done back here if there's a painful metatarsal head. What's surgery like after? After, you're going to eat, rest, go home. You're going to get some special shoes, a special shoe to wear, or some type of a device and pain medication. Some of these devices may include a surgical boot, a surgical shoe, and then a walker if you're very unstable, or a knee walker, or a wheelchair if needed. And as well, crutches may be used some of the time, depending. If your surgery is more on the base, or like a lapidus type of a procedure, you may need something like this to stay off of it, or a wheelchair. If it's done more in the front of the foot, something like a shoe or a boot may be enough. And if you're older, you may have to use a walker or a wheelchair. If you're younger, you can tend to get by with crutches. You're going to get some pain medications afterwards. This is what a typical bunion dressing looks like afterwards: holding the toe in the proper position, splinting all the toes. If you have a bigger procedure, such as a lapidus, you may use a splint that looks like this to give additional support and wrapping around the leg. Afterwards, I really encourage patients to rest, sleep, don't walk, elevate your foot, and ice your foot. Really take it easy. Take your pain medicine every 4 hours as needed. You have to stay ahead of the pain. Don't wait until the pain starts and then start taking your pain medicine, especially the first 3 or 4 days. I tend to recommend Percocet or Vicodin for pain, and then you take that every 4 to 6 hours. I like Vistaril, which can be used if you have any nausea, and then Motrin or naproxen you can take around the clock to reduce any inflammation. The one thing I want you to remember: the more that you walk on your foot, the more your foot is down, the more you're doing, the more pain that you will have. Pain is normal, but you can reduce it by keeping your foot up and elevated and only get up to go to the bathroom. For the first 3 days, the pain is going to be the worst. You have to make sure that you use your shower cover to keep your dressings dry if you take a shower. Some people tend to sponge bath, but if you are going to shower, I would use a shower cover. Also remember, you can't drive. If it's your right foot, you can't drive for a longer period of time. If it's your left foot, you don't want to drive if you're taking any pain medications, because you can make it kind of loopy. You need to ice and then also elevate your foot. The way we ice: you take a bag of vegetables or a bag of ice, put a towel around it, and you leave it on for 20-30 minutes and then switch these bags around. Make sure you don't get too much cold injury from leaving the ice on too long. So after the surgery, what happens? You have your first visit. It's usually 3 to 5 days after. This is where you do the first bandage change and you see if there's any signs of infection. If there's any redness, if there's any problems with the incision, you may get an antibiotic. We'll also do an x-ray to make sure that the alignment of the bone is correct, and if there was any screw that was placed in there, that's in a proper position. You want to do minimal walking and minimal activity, and only wear that special shoe or boot. Don't go into a normal shoe initially. At this time, at the first visit, I tend to have patients start to move the joints so they can work on the range of motion. This is important to help you have less scarring in the joint. If you do have signs of infection, we'll give you an antibiotic as well. At the second visit, you're going to have the stitches removed. That's going to be about 10 to 14 days. You're going to keep moving the joint. You may need to begin physical therapy depending on how much scarring or tightness there is in the joint, and you may have to use some type of a splinting device to help with range of motion. This is a splinting device that holds it in place, and this is something that is used to hold the toe in the proper position and help it move up and down. And also, we use a lotion or a cream on the scar. This is the lotion that I use. It's called Amerigel lotion, and this is the scar treatment that I use called Mederma. That's the second visit at 10 to 14 days. And then every 2 weeks you'll see us come to the office, and you'll evaluate to get an x-ray. At 4 weeks, at 6 weeks, you'll evaluate to get another x-ray. And when the bone starts to heal, you can begin wearing normal shoes and orthotics if needed to prevent recurrence. That's usually at 6 to 8 weeks is when all of the healing happens in the bone. Now, bone healing on x-ray is different than your symptoms. You may feel better before the x-ray actually shows that you're better. And this is an example of an orthotic that can give you some support in the arch and reduce the pressure and jamming in the joint. This is a first-rate cutout here in the orthotic. So what are the possible problems with surgery? This is the most important part if you're contemplating surgery, is to know what things can possibly go wrong. You should really ask your doctor this, because doesn't always go right. The first thing that can happen is an infection. Here you can see the signs of an infection are redness, are warmth, are pain, are swelling, and this incision is infected. To treat this incision, you're going to have to put a marking line around the area to make sure it doesn't spread, and give the patient antibiotics. If the infection doesn't get better, you may have to see an infectious disease specialist. And if it goes into the bone, you may have to have other surgery. It can be quite serious in dealing with this condition. Another problem is possible overcorrection. When we're correcting the bunion, sometimes the toe can go over if you correct it too much. This is called a hallux varus, and this you can either be lived with but maybe have a hard time finding shoes, and if you need to, you may have to have another surgery to straighten out the toe. You could also have stiffness in the joint. This is common with the surgery because of the incision, because of all the dissection that happens, and you have to work on range of motion. If you can't do it on your own, you may have to go to physical therapy or have a special device that can be used to increase the range of motion, or you may need to have other surgery to reduce the stiffness and scarring. You may have a prominent screw. You can see this procedure that had a screw that was prominent on the top, and this may need to be removed. This is removed after the bone is totally healed. You don't want to remove this too soon, unless there's any signs of infection, but you want to remove this screw. This tends to be done either in the office or the hospital, depending on what type of office that you work in. So that may happen. That's a common problem with surgery, that the screw may be more prominent than you're expecting. You may have second toe weight transfer, meaning if you fix the bunion, sometimes there can be this longer second metatarsal. You can see how it's longer than this first metatarsal. Since it's longer, it's putting more pressure down here, and this can create a problem. That's why that while osteotomy that shortens it is done. So with this weight transfer, you may have to have another surgery. That's why your doctor may recommend doing that while to shorten the length of this, so it's not relatively long compared to the other one. Because you can see this first metatarsal bone is so short, it puts greater pressure on that second. You may develop a blood clot. A blood clot can happen in the veins in the back of your leg because you're sitting around a lot, because you've had surgery, because there's been injury to the area, or as well just because you're sitting around not doing much. It tends to be more common with patients that have had recent trauma or surgery, have cancer, have pregnancy, take blood control pills, are 65 years or older, are obese, and who have limited mobility, meaning you're sitting around. So this type of a surgery is very common to have this type of a complication. You have to be careful it doesn't go to your lungs, as that can cause a pulmonary embolism, which is very dangerous. Next, there could be slow healing due to smoking. If you smoke, your skin incision may be slow to heal. Due to that, your bone may be slow to heal, so it's advised to stop smoking if you're going to have bunion surgery. You may have slow healing in the bone as well. If you can see here, this bone has actually a break in it, and this took a number of months for it to heal in because of the break in the bone. That can be due to the surgery, but as well, just the same way, the bone as well could be slow to heal, and we'll show you another picture of that later on. Another complication can be a scarring. You can have scarring over the incision, or you can have scarring inside, and that can be painful. That may reduce the motion in the joint, causing stiffness, and this needs to be treated with potentially laser treatment or topical treatments that can help with the scarring, or revision surgery. This is a very common one that is difficult to treat: nerve pain. As you can see in your bunion, where the incisions are done, one incision on the side, and sometimes going over and dissecting in the side here to correct that tendon that's pulling, you may injure some of the nerves. And that can give you numbness, tingling, burning, pain, or even chronic pain. A lot of these symptoms are only temporary until the swelling comes down, until your foot feels better, but sometimes there can be chronic pain from a procedure, and that can be difficult. Sometimes the nerve can be cut, and it's a challenging thing to deal with. You had a non-painful bunion, and you decided to have surgery, and now you have a painful foot due to the nerve. So you really have to consider what you want to do and what type of treatment you want. Sometimes you can also have something called no toe purchase. So for example, the bunion, it may be lifted up because of the procedure that was done and be elevated, and as well the second toe, because of a hammer toe procedure or that while osteotomy we talked about, that shortening osteotomy, you can have the toe lifted up off the ground. Those are both cosmetic things, but they may be painful as well, and they may be bothersome to you. So those are something that are common. You can also see in this, she has a little bit thicker of a scar in that toe as well. You may also have loss of blood supply to the bone. Do you see the bone, this cut? This is a proper cut for a bunion, but this didn't heal because of poor blood supply. This can either be from the type of surgery, it could be from a patient that smokes, it could be just from the patient's bone, but this is very hard to heal and actually hasn't healed because of this lack of blood supply to the bone. So all those are common, not common, but when we talk to patients, we don't want to give them percentages because it doesn't matter. If you have one of those problems, it's 100% to you. So it doesn't matter if the nerve problem is 5% of the time. If you're that one person that had it, it can be really detrimental to you. And then the last question that everyone has is, well, will this bunion come back? Normally, if the correct procedure is done, it usually does not return. And also, you need to correct the deforming forces. And this can be done with orthotics or proper shoes that are worn. So all these things are very helpful. I hope you found this to be comprehensive. If you have things that you'd like to add, please comment on this video. And as well, if you'd like some additional resources, you can go to the apma.org, foothealthfacts.org, or the APMA to find a podiatrist if you think that you need help with your bunion and you would like bunion surgery.